for coming out tonight. My name is Noral Farawi, nurse practitioner with the LMPCA Executive Council. I'll be moderating for tonight's town hall, and I'm very pleased to have you all here today. We have some excellent speakers lined up for tonight to present about great programs available for our patients. But first, I'd like to welcome Dr. Vineet Nair, who is one of our co-chairs of the London Middlesex Primary Care Alliance, to share a few words.
Yeah, thanks everybody. Thanks for attending tonight. I know everyone's busy these days with all things COVID and life in general, but no, it's a great opportunity to get together tonight. And as the Nor said, I'm Vineet. I'm a family doctor here in London, and I'm the co-chair of the Executive Council of the London Middlesex Primary Care Alliance. So we're a fairly new organization as we're trying to organize primary care into a kind of a cohesive unit that to help advocate and express our concerns for our patients so we can improve the healthcare system as a whole. We've been kind of started out as a group a number of, well, I guess early last year, almost a year and a half ago. It's just a group of leaders working together, meeting every couple of weeks to talk about the issues at hand. And of course, this last year and a half has really been one where we've seen the importance of organizing as a sector with COVID, with the challenges of practicing with COVID and PPE and testing and then vaccinating and helping roll that out. And then of course, there's always the OHT that's being in development as well. So we are a more formal organization now. We're trying to get them more formal as we even go forward here, is trying to making sure we include all of the voices of primary care. So our goals over the next little while is to continue to formalize our governance of primary care, continue to reach out to you with town halls, with useful information through our newsletters, and keep on advocating for primary care investment, whether it's in resources to help support our work, but also resources like this. We're talking about increasing our team as we kind of try to control, try to take care of our patients, but without maybe not having the teams that everybody has. I'm a faux non-fit doctor, so this kind of talk today where we talk about how we can access team resources to help care for my patients is really exciting for me. So thanks again for attending tonight. I hope you get some good interesting information on how we can expand our teams and help care for our patients. So thanks again for coming. I'll hand it back to you there, Nora.
Awesome. Thank you, Vineet. It's now my pleasure to introduce our first speakers. Dr. Christopher Lishka is a clinical respirologist and researcher. He's the head of the Asthma Research Group, Windsor, Essex County, Inc., which has the Best Care program. Dr. Lishka is a physician at LHSC, a lecturer at Western University, and a researcher at Lawson Health Research Institute here in London. Dr. Lishka is the respiratory lead for Best Care. He's also joined by Madonna Ferrone, who's a respiratory therapist and certified respiratory educator. Madonna is also the provincial coordinator of Best Care. Take it away, guys.
Okay. Good evening, everyone. Thank you for the introduction, Noor, and thank you to the LMPCA for the opportunity to present tonight. Let's get the slides queued and I'm good to go. So tonight I have two main objectives, but as an opener, really Best Care as a core principle is there to support primary care physicians in the delivery of best practices for chronic disease management on site in their practice. So tonight I have two jobs in 15 minutes, more or less. A brief COPD guideline overview and a brief overview of how Best Care can support you to deliver COPD and heart failure guidelines in your practice. Let's ground the discussion in a brief case. This is Claire. She's 78 years old, was diagnosed with COPD about 3 years ago. She has moderate airflow limitation with an FEV1 around 58% and objectively confirmed diagnosis of COPD. She is short of breath based on the MRC scale of 3, and she has a mildly reduced quality of life. In addition to her medical profile, she also has some social issues that are relevant. She is a widow, and she herself is waiting for long-term care for a variety of medical conditions, including rheumatoid arthritis. She's currently on a dual bronchodilator with a short-acting beta agonist with Ventolin PRN. She has some issues in terms of her maintenance care over the course of time, She's not received the influenza vaccination on an annual basis. She has not received pneumococcal vaccination. And she regularly has flare-ups of her underlying COPD. She gets the typical story. Every time I get a cold, I get worsening cough, more purulent secretions, more short of breath. The cold settles into my chest. And this past year, she had 2 such flare-ups requiring prednisone and antibiotics. So she is quite symptomatic with shortness of breath, MRC3, and she is a frequent exacerbator based on her current profile. So let's take that case and discuss it in relationship to 6 take-home messages from the current COPD guidelines. The focus now on guidelines is on managing symptoms, reducing them as much as possible, such as in Claire's case, and exacerbation prevention. So looking to take that individual experiencing lots of flare-ups and reducing the frequency or eliminating exacerbations. And where exacerbations cannot be eliminated, then acting early by having the patient self-activate an action plan as indicated under number 2. On discussion about pharmacotherapy tonight for COPD and later for heart failure, we'll be talking about the pathway to triple or the pathway to quadruple therapy. I'm going to focus on this notion of the pathway to triple therapy for the pharmacologic treatment of COPD. In general, milder patients, 1 bronchodilator, a long-acting antimuscarinic, is generally the starting point, such as cases like Claire, who are still symptomatic or still experiencing exacerbations. The pathway from mono is to dual bronchodilator therapy, and then eventually to triple therapy with an ICS, a long-acting beta agonist, and a long-acting muscarinic agent. And so the general pathway, mono, dual, triple, is a simple rule to consider in the management of patients with COPD. Advancing when needed because symptom control is inadequate or exacerbation prevention is inadequate. Now, to that simple rule, there are a couple of modifications. For individuals at a high risk, like Claire, you might decide to start on dual therapy, and that would be a guideline-based decision. That dual therapy could be an ICS LABA, so something like Symbicort or Brio, for example, or a LABA-LAMA combination, a dual bronchodilator. So the exception is skipping a step, advancing therapy more aggressively in individuals at high risk of exacerbation because of frequent exacerbation profile. The other exception would be those who have some features of asthma. Those with asthma COPD overlap, they should receive treatment for their asthma, the inhaled corticosteroid. They should receive treatment for COPD, the long-acting beta agonist component. So we would generally start them on an ICS LABA combination and then advance to triple if need be. Number 4, as a general rule, dual bronchodilators, mono or dual for mild or moderate disease, triple therapy for moderate or severe disease. In general, those people that advance to triple therapy and require all 3 drugs, we do not step them down when they are better. The sense is that this is a durable phenotype. These are individuals that will need to stay on that advanced treatment. So we talked about focusing on symptom reduction and exacerbation prevention in our focus, but there will be individuals that will still exacerbate even with the best preventive strategy. And so for those individuals, we want to talk about lung attacks. We want to understand the severity for the individual and also for our health system. So an exacerbation or a lung attack is a sustained worsening, 2 days or more, and that typical Claire story. increased cough, increased sputum purulence, more short of breath. Those individuals that have a bad enough attack that they are hospitalized have a relatively high mortality rate over the course of the next year, and their in-hospital mortality is also measurable. For patients, these are serious life events with consequences. Prevention, first strategy, early intervention, second strategy, and the GOLD guidelines, the Canadian Thoracic Society guidelines, advocate for collaborative self-management for patients to take action early after 2 days of a flare-up to initiate treatment, including taking more inhalers and a prescription for antibiotics and prednisone. For those individuals that exacerbate frequently or that have been hospitalized with a severe exacerbation, the guidelines and our program advocates that this patient should have a prescription that they can self-activate for prednisone and for antibiotics. And so within the Best Care program, this is a program standard, and I would recommend it as an evidence guideline-based strategy. Now, let me put on a different hat for a moment, and that is to say, that is the very brief synopsis of current COPD guidelines. But there are many elements to the guidelines and a huge number of recommendations. And so as a guideline writer, as chair of the Canadian Respiratory Guidelines Committee, when I'm wearing that hat, I recognize fully that while we have produced an excellent synopsis of the evidence, the real challenge is making it happen in the communities that we serve. And so what we're asking primary care docs to do based on our COPD guidelines is very difficult to achieve as a solo practitioner and within the current care model that exists. And then beyond the medical, pharmacologic, and non-pharmacologic issues, there are also complex issues that patients face beyond the medical model. And so I'm not going through all of these elements, but suffice it to say, these are themes that I have pulled out from about 100 case conferences from patients in primary care. Multiple morbidities, language barriers, health literacy issues, smoking, financial issues, dementia, et cetera, et cetera. And so beyond the medical model, there are the biopsychosocial issues that also need to be addressed. So what is Best Care? What is the Best Care program? In a nutshell, a complete knowledge translation module for primary care, managing all elements of evidence-based care and delivering them in your practice under your supervision, plus the case management that's required for those psychosocial issues not fully addressed. What we're hoping is that lots of primary care docs in our region and across Ontario Health West will say yes. In fact, many already have. This is a program that works very well. It's designed to work in primary care. The testimony there is that in the last 2 years, we've done about 13,000 visits for COPD alone. And in our program overall, we have done 61,000 primary care visits. It works in primary care. Our retention rate over the past 2 years, about 100%. All elements of evidence-based care, from diagnosis right through, are covered by the certified respiratory educator, the patient working with their primary care provider. Who are the members of our team? We have certified respiratory educators, certified cardiac educators, registered respiratory therapists. These are highly qualified, highly trained individuals that are delivering evidence-based best practices in every visit. How do we think about this model overall? We think about the acute care system, and if I might, in Ontario, about 200,000 hospital days every year for COPD exacerbations, about 270,000 for heart failure exacerbations or flares. These are significant and huge costs to our health system that have major impacts on individuals, on the individual's health. And so there are health system issues, there are patient issues, and the hospitals have this challenge to deal with. Best care and other programs like community paramedicine, palliative care, and the primary care sector can have a potent influence upstream to prevent acute care hospitalizations for these chronic conditions and others. And from our program data, I am confident that we are seeing reductions of 40 to 60% in hospitalizations based on the upstream approach in primary care, that these are sustained, and that we are seeing similar dramatic and sustained improvements in quality of life for patients that participate in best care. So that's my time for tonight. If for those of you that are part of the Best Care program, thank you for your support and participation. For those of you that are not, speak to a colleague about it, reach out to Madonna Ferroni or to me. Madonna's email is there. And in terms of CME, we would love to return at some point to this format or others organized by LMPCA to discuss cases in detail. Thank you for your time.
Wonderful. Thank you, Dr. Lischka. Next, we have Dr. Robert McKelvey, who is a cardiologist and subspecialist in heart failure. Dr. McKelvey is affiliated with Western University and St. Joseph's Healthcare in London. He is also the cardiac lead for Best Care. Take it away, Dr. McKelvey.
So Bob, I think, am I advancing your slides?
It looks like you're on mute, Dr. McKelvey.
Thanks. Yeah, Chris, I think that's what we're going to do.
Okay.
Yeah.
There we go.
Great. Thank you. All right. So we're now going to move into heart failure, and we'll start off with the heart failure guidelines. Next slide. So I think, first of all, it's important to recognize that with regards to heart failure and mortality, if you compare it to cancer, heart failure outcomes are worse than most of the common cancers that you will see and be involved in treating. So for men, prostate cancer has a better outcome, colorectal cancer and bladder cancer do, breast cancer for women, and even things like colorectal cancer. So we need to realize that heart failure, the outcome for heart failure is worse than many common cancers, and in fact, you could consider it cancer-like in the way it behaves and presents. So next, just push a button. So no, go back one. Sorry. Thanks. So it always leads me to state, why are heart failure patients not managed with the same urgency as patients diagnosed with cancer? So I'd like to have you keep that in the back of your head as we go through the presentation. Next slide. Over the years, there have been a number of therapies developed to treat heart failure. This slide just reflects the findings from the ACE inhibitor studies, and for well over 25 or more years, we've used ACE inhibitors as the backbone, gold standard therapy for heart failure management. And if you look at the consensus study on the left of this screen, this represented the earliest of the ACE inhibitor studies in a population of very sick heart failure patients who had a mortality rate of about 50% over a year, and ACE inhibitors reduce that significantly. And if we go across to SOLVE treatment, where patients had heart failure, reduced ejection fraction less than 40%, and were symptomatic ACE reduces mortality. The prevention group, solve prevention, individuals with reduced ejection fraction, but they were asymptomatic. Again, significant reductions in clinical events. AIR, SAVE, and TRACE were post-MI studies using ACE inhibitors in people with reduced ejection fraction. In this setting, again, significant reductions. In the ATLAS study demonstrated that we should shoot for the target doses for benefit. Next slide. As well, beta blockers, as you are well aware, are used to manage patients with heart failure, reduced EF. The first studies that came out were carvedilol studies, the US carvedilol and Copernicus, demonstrating that in individuals with moderate and with Copernicus more severe heart failure, benefits were obtained. The MERIT-HF study with metoprolol CR, metoprolol succinate, which we don't have in Canada, demonstrated benefit. And the CBIS-2 with bisoprolol, which we do have in Canada, again, reductions in mortality and morbidity. So I would just remind you that the metoprolol we use in Canada is metoprolol tartrate, and it is not evidence-based when it comes to the management of heart failure patients. Next slide. Over the years, obviously, patients we found or we knew would be intolerant to ACE inhibitors. The CHARM alternative study demonstrated that using an angiotensin receptor blocker, candesartan, in patients who were intolerant to ACE inhibitors compared to placebo resulted in a reduction in mortality and morbidity. So we demonstrated that in patients who were ACE intolerant, candesartan, the ARB, would provide similar benefit. Next slide. As the years passed, further therapies were added. This slide just shows the emphasis study with eplerenone. However, the original study, the RALS study with spironolactone, done about 20 years ago, demonstrated that in very sick heart failure patients, the mineralocorticoid receptor antagonists, spironolactone, reduced mortality and morbidity. Emphasis using eplerenone demonstrated that in the less sick heart failure patients, the MRA eplerenone reduced mortality and morbidity on top of ACE and beta blocker therapy. So now we use MRA therapy routinely in patients with heart failure. Next slide. Well, you're probably aware of the Paradigm study using the drug Entresto, which contains sacubitril and valsartan, so it's a combination therapy. And when Entresto was trialed against enalapril head-to-head, it demonstrated that Entresto was superior to enalapril. So we moved to thinking that Entresto is better than ACE inhibitor therapy. So Entresto was moving up towards being a first-line therapy. The Pioneer study on the right examined the question whether or not Entresto could be started in patients who had not previously been treated with an ACE inhibitor and or could be started while the patients were in hospital. This slide just shows you that the reduction in natriuretic peptide was significant with Entresto compared to enalapril, and the clinical outcomes were improved in patients taking Entresto compared to enalapril, giving us confidence that Entresto could be started potentially as a first-line therapy and could also be safely started in hospital in patients that had been admitted with an exacerbation of their heart failure. Next slide. So over the years, you can see that as we move from the bottom of the slide, just using ACE inhibitors, and we added therapies in, that regarding all-cause mortality, cardiovascular mortality, hospitalizations for both all-cause and heart failure, the point estimate, the risk was decreased. So we got to the point that we recommended in the guidelines that there should be multiple therapies used in heart failure patients to reduce mortality and morbidity. Next slide. So most recently, just within the last 2 years, and more data are coming out about the SGLT2 inhibitors. This study, the DAPA-HF study, was designed as a heart failure trial. And what I mean by that is they randomized patients with heart failure, reduced ejection fraction, less than 40%. And it didn't matter whether or not they had diabetes, they were randomized into the trial. So now dapagliflozin was being tested as a drug to treat heart failure, not as a drug to treat diabetes. And here you can see that dapagliflozin added on to ACE beta blocker, MRA, or Entresto beta blocker and MRA, that the addition of dapagliflozin further reduced mortality and morbidity. Next slide. And this slide just demonstrates that in this day and age, and it will give you a rationale for the next slide, that we would use the combination of an ARNI, which of course is Entresto, beta blocker, which would be bisoprolol or carvedilol, MRA, spironolactone or eplerenone, and an SGLT2 inhibitor, and that the benefits of using all 4 medications together in a patient with ejection fraction less than 40% is better than the old approach we had, which was just ACE beta blocker and just MRA as therapy. And you can see at the bottom of the slide that in terms of an individual at the age of 55, there's 8 additional years free from cardiovascular death or heart failure hospitalization. And those over the age of 65, which are the majority of patients that have technology. It's out of control. I can't stop it. Anyway, the majority of patients are over the age of 65 with heart failure. Again, there's an additional 6 years of overall survival. Next slide. So the 2021 heart failure guidelines now position these 4 groups of drugs all on the same level. In other words, an ARNI or an ACE or an ARB, depending on the situation, would be started. If an ACE or an ARB was started initially, then you would substitute the ARNI, which of course is Entresto. Beta blocker would be initiated, the MRA would be initiated, and the SGLT2 inhibitor would be initiated. And the thinking behind this is it wouldn't be a matter of start a drug, reevaluate. If they seem to improve, you don't go any farther. The idea would be to get all 4 drugs started appropriately. Then you would continue to reevaluate the patient. If the heart rate remained above 70 in sinus rhythm, you might add on a therapy, ivabradine. There are other therapies you can see that you might add on as well, depending on how the patient behaved to the first, the initiation of the first 4 drugs from each of those 4 groups. But the important thing is that 1 drug from each of these 4 groups would get started. Next slide. So then it's important then to, as this slide articulates, titrate to the maximum tolerated doses of heart failure medications recommended in the guidelines to reduce mortality and morbidity in left ventricular systolic heart failure. And what I mean by that is we are not using these drugs to treat blood pressure. We're using them as disease modifying agents to reduce clinical events. So even if the patient's blood pressure was sitting at 120 or 110, you would continue to optimize these therapies as tolerated. Every attempt should be made to titrate medications as soon as feasible after the diagnosis. As it's stated here, it is reasonable to aim for titration of these therapies to target doses or maximally tolerated doses within 3 to 6 months from diagnosis. This is an important change in message from the Canadian guidelines. It may come as a surprise to you, but it is not unusual to have a heart failure patient not optimized after a year or a year and a half. There are many times I see patients come back and it's been 2 or 3 years and they're still on suboptimal doses. So the guidelines state very explicitly that 3 to 6 months, and furthermore, they really emphasize that it should be within 3 months. And most heart failure experts would say that they should be started on all 4 of those therapies, if tolerated, within a month, and then continue to up titrate from there. As well, the Canadian guidelines have stated that the initiation and titration of standard therapy should be embraced by non-specialists. In other words, what we're talking about tonight is collaborative care, that we as a community of healthcare providers can help appropriately optimize these patients. We do realize that initiation of medicines can be challenging, as individuals with heart failure frequently have multiple comorbidities, numerous medications, and often move between acute and primary healthcare sectors. Again, important to have communication and collaboration as we manage these patients. As you're starting these therapies, there's no proven superior approach to medication initiation and titration. In other words, you may want to start the beta blocker first because that is indicated. So the educator that Chris had talked about earlier will work with you to achieve this goal. Patient-specific titration plan would be collaboratively developed. It would allow close follow-up with patient and monitoring of blood work and symptoms. There would be clear communication with the primary care provider and specialists as needed. In other words, it may be that you would relate with the cardiologist who you're collaborating with, or the heart failure clinic in London. It's important then to identify adherence issues, whether the patients are properly taking their therapies. And I think importantly, down at the bottom in full cap letters, is communication is key. We need to talk to manage these patients, and it truly needs to be a collaborative approach. Next slide. So in terms of collaborative self-management action, the patients will be given this type of algorithm with regards to helping them self-manage their heart failure. The green zone would imply to them, as you can see on the slide, that symptoms are under control. The yellow zone would indicate that maybe things are getting out of hand and there needs to be further changes to help prevent further deterioration. And the red zone, of course, would suggest that things have actually spiraled out of control in a sense, and that they should be going to the emergency room to have proper assessment and further management. Next slide. Right, so that's the end. If there are any questions, I guess we can take them, or we could continue on.
Yeah, thank you, Dr. McKelvey. There will be some time after the next presentation for some questions. But what we'll do now is we'll switch gears slightly to talk about community paramedicine, who is led by Superintendent Dustin Carter and Assistant Superintendent Brittany D'Angelo. Due to scheduling changes that occurred for tonight's town hall, Dr. Kathy Fold will be presenting about the CP-LTC program. Dr. Fold is a family physician with a focused practice in palliative care. Dr. Fold is also a part of the medical advisory group within community paramedicine.
Thanks, Nor. I think Chris is going to pull slides up for me too. Sorry, Chris. I'm going to talk through someone else's slide deck, and I apologize if I don't know the deck entirely tonight, but this is basically a new program that's been funded by the Ministry of Long-Term Care, not by the Ministry of Health, and it's been in response to the growing increase in patients who are waiting placement in our community. Next slide. And the agenda is really, I want to tell you about what a community paramedic is. I want to teach you about how they can enhance and improve your practice and how you can link with them to support the patients that you care for. Next slide. So basically, most of you will know that paramedics are government-regulated health professionals, and they provide care under the Paramedic and the Ambulance Service Act as part of our emergency response system. And they can perform all kinds of controlled acts and advanced medical procedures. And in general, they respond to physicians that are out of what we call base hospitals. So London Health Sciences Centre is our base hospital, and there is a physician there who will give directives and orders when they're on call in the emergency department. There are 4 different types of paramedics, and the 2 that are the type of paramedic that is involved in the community and working with this program are the primary care paramedics and the advanced care paramedics. Next slide. This is just the geography of what our Middlesex, London community paramedics cover. So it's an extensive region, and there are 14 different paramedic stations and over 350 paramedics. In order to do this program and to train community paramedics and advanced care paramedics in management of patients with diabetes, COPD, CHF, frail elderly, and palliative issues, they've undergone extensive training, and I had the pleasure of being part of that and providing some of that training. Next slide. So how will they help to support patients through this program? As I mentioned, it's a model that is available through a non-911 number. So we are teaching patients and our system to be able to contact community paramedicine with a direct line or a direct referral in. And their Ministry of Health funding is really directed towards patients who are on the long-term care list or waiting long-term care placement, or who would be eligible for long-term care placement, or who are palliative at home. And you can see that there's a lot of overlap between the patients that both Drs. Lishka and McKelvey talked about already, because both COPD and CHF are terminal illnesses. The interesting thing, I think, for all of us is to remember that there are about 1,000 patients that are currently on the long-term care waiting list. And the primary goal of this is to reduce patients presenting to the emergency department and admission for hospital. We want to strengthen the on-call system and the support that we're giving patients in the community. Next slide. So this is a really important slide, because I think that a lot of us are confused about why community paramedics and why are we not funding more nurses in our community. And I think that it doesn't mean that we don't have shortages of nurses, don't have shortages of PSW, that isn't something that needs attention. But this is an acute response by the Ministry of Long-Term Care to expand our teams in the community, and paramedics bring a host of skills that can augment and support our nursing and our PSW colleagues. So it's not meant to replace the care, it's not meant to compete with the care, it's meant to augment. Next slide. It's important to also remember this is 24/7, 365. And so for patients in the community, this is something that is really quite new. We have had palliative care on call. It's been a privilege to be part of that on-call community for most of my career. But this is extended beyond patients who are at who might be on our palliative care teams. Next slide. So by working together, and this is why it's so important that the word gets out to all family physicians, between 8 in the morning and 5 in the afternoon, as an MRP, family physicians, nurse practitioners, you can have the community paramedic on your team in the community as your eyes and ears for patients that are housebound. At 5 o'clock, there's an on-call support from a team of palliative care physicians. There are 8 that have stepped up to do this on-call work for the first 3 months of the program, between 5 and 8 in the morning. And when we are called about any of your patients from 5 p.m. to 8 in the morning, then we would reach out to you and give you reports on what's happened with your patients. But it's really important that in the daytime that the community paramedics can reach you, can get hold of you in a timely fashion. Next slide. I think that this is, I've probably already mentioned this, that it's just why community paramedics, they're timely. An example I can give you is a frail elderly patient who is at home with gastroenteritis, waiting long-term care placement. In order to get intravenous fluids from Urix, our local home care provider, it can take up to 4 hours to get the fluid out, and then it can take time to get the nursing agency to have someone out to put an IV line into someone. Community paramedics can deliver or turn that around in a shorter time frame, and they have experience in delivering IVs. And so just one example, also on call for patients that might go into status epilepticus, might have terminal bleeds, might need point of care blood testing done, blood results done. So they're mobile, they're responsive, they're timely, and they're working 24/7 with us. Next slide. This is some of the expanded scope that can be done in the community. Mentioned the point of care testing, both for a nasopharyngeal for COVID, urinalysis, blood tests are being done now. Vaccine administration, if you need help with that for patients that are housebound. Chronic diseases, we've talked about COPD and heart failure, but dealing with patients with hypoglycemia or diabetics that need support, IV access, fluid hydration, and then there is a list of palliative care directives. They carry what are called symptom response kits and medications on themselves. So if we don't have a symptom response kit out in the home like we would with someone who is palliative, then we can make sure that the community paramedic has a directive from you to administer those medications. Next slide. And the benefits to us, I think it allows primary care to be very flexible with an expanded team. It allows us to be 24/7 in the community, and it really allows access to more services in the community. I think most of you know that right now, if we wanted a laboratory work done at home from one of the private labs, the patient would need to pay to have that done. And community paramedicine can provide point of care testing. Community paramedicine as well. I forgot to mention that they can be involved in doing a pronouncement of death with patients and with families in the same way that our nursing SPOs are. Next slide. So who's eligible for the program? Patients on the waiting list for long-term care, those who will soon be eligible for long-term care, and those eligible based on home and community support services care. And the care coordinator would recommend or could make that referral, but you as family physicians can also make that referral. You would need to review the patient care directives, be comfortable to sign off on those care directives. They are already vetted with the CPSO, the CMPA, and the medical advisors. Dr. Dan Pepe is the medical advisor for community paramedicine. Dr. George Kim and Dr. Copeland are the advisors for the palliative care directives that are included. You'd complete the referral form and then you'd sign off the directives. You return it to community paramedicine, making sure there's a contact number for them to be able to reach you between 8 and 5. Some of your patients will be referred by home care. Some will be referred by perhaps even specialists can refer. And then you yourself can refer as well. And patients, step 5, care for your patients in the community. Any of these forms, an info sheet about the program, the referral form, the directive sign-off are all going to be available on the LMPCA website that was mentioned at the beginning of the town hall. If there are any questions or concerns about those, please feel free to reach out to either myself, to Superintendent Dustin Carter, or to Dr. Dan Pepe. Next slide. There's some emails here that will be given out to you. I believe the deck is going to be made available and the emails are made available. And if you have any questions, don't hesitate to reach out. Next slide.
Wonderful.
Thank you.
Thank you, Dr. Folds, and thank you, Dr. Lishka and Dr. McKelvey, for also introducing us to these wonderful programs for our patients in our practice. I'd like to now open up the floor for about 10 minutes or so for any questions or comments. Feel free to type in the chat box or unmute yourself.
Kathy, it's Chris. So for the paramedicine program, then for 24 hours a day in the region, there will always be someone that has one of those 2 certifications that you've identified that would be available across what is a huge geography.
There are actually 3 buses on in the daytime and 1 bus at night. And then in the London Middlesex, and I'm not the expert on this, there might be someone from home care on here as well, but I believe there are 3 nurses on at night as well, depending upon availability. So the community, in terms of coverage, you can see that by having, we basically expand our team of first call response in the community. It's a huge expansion. I have a question to Dr. McKelvey because I get asked this all the time. In fact, I was just in a home today with someone with a blood pressure of 88 over about 48, 50 on quadruple therapy. And the family and the nurse were concerned that I needed to stop some of those medications that were lowering the patient's blood pressure. The patient has congestive heart failure. How do you deal with hypotension, dizziness as a morbidity from potentially the medications and the reduction in morbidity, mortality from the medications? And at what point does that for you factor in?
Yeah, so it is a balance. And I think, first of all, there needs to be an assessment about whether or not the patient has symptoms of orthostatic hypotension and the degree of severity. So it would run the spectrum from they feel maybe a little lightheaded if they get up too quickly to they feel very lightheaded and there's risk of falling even if they're getting up more slowly. And then after you've made that assessment, the next thing would be to look at their diuretic therapy And what we generally do is start to decrease the dose of diuretic therapy, because quite often in combination with those 4 medications, the patient could end up being over-diuresed. So if the patient's on Entresto, it has some degree of diuretic effect. Obviously, the mineralocorticoid receptor antagonists have the same effect, and the SGLT2 inhibitors as well. So our approach is to back off on diuretic therapy, and we try to maintain those 4 medications, because, as I said earlier, the disease modifying. In other words, it's not just there to reduce symptoms, and they also reduce hospitalization. So even I would say, even if the patient is palliative, I would not back off on those medications, because it's helping the individual feel better. It potentially will be keeping the person out of hospital. So we adjust the diuretic therapy. If you do get to the point that you need to start with one of those disease modifying drugs, then I would consider, maybe backing off on the SGLT2 or the MRA. And finally, I think it's important to recognize that patients with heart failure run low blood pressures. So to my point, if the family, because the pressures are measured in the home, or if the nurse who's assessing the patient comes across low blood pressures, there shouldn't be concern at all unless the patient has orthostatic symptoms that are severe enough, as I discussed. And finally, years ago at a heart failure meeting, one of the heart failure specialists said, I don't even use a blood pressure cuff, because if the patient isn't symptomatic, I'm going to continue with the therapy. And if I measure their blood pressure and it's low, that's not going to change what I'm doing. So the heart failure patient is a different beast, so to speak. They will run with low blood pressures. And the challenge for the healthcare provider is to work with that, kind of ignore it, and continue with the therapy unless the reasons occur to do otherwise. But by and large, the pressures are low. Don't let that concern you, and adjust the diuretic as necessary.
That's fantastic. Thanks. I don't know if there's any other questions. Oh, Julie's got one.
Hi, thank you very much. Those are wonderful, informative presentations on topics that can be hard for me to manage in my office. One question I have for Dr. Lischka is about monitoring COPD, sort of technically, like how do we monitor it? I guess I'm curious to know, what do the RTs do as they're monitoring in the home? Are they doing some sort of PFT assessment? So I'm interested in knowing a bit about that, and a bit about how you recommend a family doctor order PFTs and respond to them. And should we order them in there's a few community places or hospital-based? Just a little more detail about PFTs would be helpful. Thank you.
Thanks. I think the primary role for pulmonary function testing in COPD is in first confirming a diagnosis. And that has been a real challenge across our system. And I think a particular challenge for primary care, because access to spirometry has a long history of being difficult. And as a technology, or in terms of interpretation, it is not as well understood, say, as echocardiography or other, common test procedures. So one of the, I think, part of the philosophy of best care is to work to support primary care to close existing gaps. And so our educators are all taught and perform high quality spirometry on site in your practice. They'll do pre and post bronchodilator testing in order to help support an objective diagnosis of COPD, or to exclude it, or to suggest perhaps that asthma is a better fit diagnosis, or asthma COPD overlap if the reversibility is substantial. And so I think the central role for spirometry is really around diagnostic confirmation. But then it also helps over time, because I always view airways disease diagnosis as dynamic. I start today, this is what I think it is. I think it's primarily COPD. I manage it, I follow it over time, and sometimes you get a surprising amount of reversibility or improvement with treatment over time. And so I always reserve the opportunity to reassess, review, and reclassify patients. In terms of other uses for spirometry, I think periodic monitoring is reasonable. There is no recommendation for how often that should be. In individuals with more severe disease, probably annually or every other year, just to monitor what their airway function is actually looking like. But fundamentally, the monitoring is around symptom monitoring and exacerbation monitoring. I mean, those are really the key elements. But then there are, with airways disease, the challenging issues around we don't prescribe pills very often. We prescribe inhalers. Critical errors with inhalers are a common problem. And so reviewing and refining the individual and patient's technique to make sure they're adequately delivering. And so we kind of think about what the educator is doing in terms of general and self-management education, in terms of skills training, and in terms of case management, working through issues around adherence, working through issues around technique, supporting action plan development and execution. So those elements of non-pharmacologic treatment that are difficult. So I feel like I don't want to get too far off track, but Julie, is that where you were heading with the question?
Very helpful. Thank you. Thanks.
Great. We have a question in the chat box here. Dr. Lishka, can you comment on action plans in diabetics? Do we really give prednisone 50 milligrams, and is it for 5 or 7 days?
So I'll answer the last part first because it's the easiest. The guidelines always used to say prednisone 50 for 7 to 14 days, or half to 1 milligram per kilo, capping out at 50. But a few years back, there was a New England Journal of Medicine study that compared 14 to 5 days. 5 days is adequate, 14 is no better. Do I use prednisone 50 in diabetic patients who are having a COPD exacerbation? Yes. Do I advise them that their sugars will go up and that we should be monitoring sugars? Yes. Do I advise them if they step up any therapies while they're on prednisone, that when they stop after day 5, they'll have to review that? Yes. Do I have a lot of trouble with diabetic, a severe loss of control of diabetes with prednisone 50 for 5? No, I don't. So it's a concern. I think you can't ignore the impact that prednisone can have on blood sugar control. But in my experience, it's seldom a big problem. But COPD exacerbations in high-risk individuals is a big problem. And so, especially for those that have had severe flare-ups or more severe disease, I'm pretty unreserved in giving prednisone. My experience has been over time, patients get antibiotics, their sputum clears up, they have less cough, they're still short of breath. They get the prednisone, it finishes the job. So I do. I think it's safe with caution to do it even in patients with diabetes.
Wonderful, thank you. I actually have a question myself, just in the context of how Best Care can help our practices. How can we go about finding our patients with COPD?
Well, I think that is one of the big challenges, as you know. If we want a proactive health system, then part of what we need to do for COPD and probably for heart failure as well is go and look for those higher risk individuals. We do it for diabetes. We find our diabetics, we bring them in, we use a diabetic flow sheet. We have specific proactive preventive steps that are taken in diabetes. For COPD for sure, and Bob can comment if he would agree if it's the same for heart failure, but very often it's fairly reactive. And so part of the strategy that we'll use, that we've used through Best Care, is using QIDS-based validated EMR searches, and then have those searches curated by the educator to identify those individuals at risk and proactively invite them back to care. And maybe if I'm brief, Bob can comment, but one of the comments that I know that we've had back from primary care about heart failure is, what about this pathway to quadruple, Dr. McKelvey? I'm hearing what you're saying, but I'm not seeing my specialist colleagues doing it, and we're not doing it very often. Why is that? That's the proactive question, I think.
It's a very proactive question, very provocative question as well. I think the answer, so the short answer to that is the Canadian guidelines, in 2021, just a bit prior to that, we would be saying they should be on, the three, ACE or Entresto, beta blocker, and MRA, and now the four medical therapies. And I guess oftentimes all people treating heart failure are not equal, because I see it as well quite often that patients aren't optimized fully. I actually saw a patient today, or actually a few days ago, in the heart failure clinic that had been referred to us, and the ejection fraction was 25 to 30%. And the referring physician had sent the patient to the arrhythmia group for an ICD, which, if you look at the number, 25 to 30% would be appropriate to refer for an ICD. But the patient had not been optimized on any heart failure therapies that we would consider 21st century. And I wrote my arrhythmia colleague and I said, I think we should reconsider before we put the ICD in. And his response back, and I said, because this patient has not been optimized on, or attempted to be optimized on all four therapies. And he wrote back and said, yes, I agree. He said, as arrhythmia people, when the patients are referred to us, we assume that they've been fully optimized or the attempt has been made. That often, it's often the case that that doesn't take place. So I think this is a situation where Best Care helps in the heart failure situation, because now you have the educators saying, the guidelines are saying, use all four. I can help you with this. And then I'm going to say you have the confidence to move forward and think, well, this is really what needs to be done. And that's the advantage of having someone like an educator embedded and helping you. And years ago, I did a study with Catherine Demers, who is a cardiologist in Hamilton, and we provided a CME to a group of family physicians and about the guidelines, remembering this is 20 some years ago now. And then we randomized these family physicians. One group had the knowledge of the guidelines from CME, plus they had an educator working with them in their practice. And the other group was just randomized to usual care, which was, of course, just the CME guidelines but no educator in the practice. And what we found was that the family physicians who had the educator working with them better optimize their patients. They reach targets for ACE, they reach targets for beta blocker, whereas the other group was not. So that was like preliminary data supporting what best care is achieving now for heart failure patients. So incredibly important. And I realize that as family physicians, you see all sorts of things coming back from various specialists. But if you ask Stuart Smith, Ryan Davey, or Savvy D, they would give you the same answer that I've just given. You need to optimize all 4 drugs to the best of your ability, full stop. And anything short of that is not following the guidelines and doing a disservice to your patients. The other, if I may, just for a moment, comment as well, because Chris, you mentioned about proactively looking for patients. I guess someone asked a question about COPD patients. And then Chris mentioned about heart failure as well. It's important to realize that, as we've said, about 2% of the population has heart failure with symptomatic heart failure. And that amounts to well over 250,000 people in Ontario. There's another 2 to 5% of individuals who have asymptomatic heart failure. And they're, depending on where you make the ejection fraction cut, of course, the percentage will change. But about 2 to 3% will have ejection fractions less than 40%. And we did a study years ago. Again, we screened we had family physicians involved, and we screened their practices with echoes. So what we did was we said to the family physicians, identify people who were at higher risk of potentially having left ventricular dysfunction. So previous MI, someone with multiple risk factors, diabetes, hypertension, smoking, and they weren't identified as having cardiac dysfunction. In other words, we couldn't find anything on the chart in terms of cardiac function. If they were on an ACE inhibitor, it wasn't being used to treat heart failure. And what we found out of those 500 or so patients, that about 10% had some form of cardiac dysfunction that was asymptomatic. They either had an ejection fraction less than 35 or 40% or diastolic dysfunction, all of which would lead them down the road to developing heart failure symptoms at some point in time. So really, you've got to understand that these patients with heart failure just don't drop out of the sky. There is a lead time with regards to the development of these symptoms. So if you're screening if you've got a 70-year-old who had a previous MI and they're coming in and they're saying, you know, I feel a bit more short of breath than I used to. I mean, the penny has to start to drop. And this is where you might look. And if you haven't had an echo on that patient for 5 or 6 years or more, maybe it's time to do the echo and start thinking about heart failure. So very important to think about it in a preventative way and get started earlier with therapy. So I know I rambled on there, Chris. Sorry, I'll stop there.
No worries. Thank you. We just have about 1 minute left, but Vineet, you have your hand up there.
Yeah. Oh, thanks. I'm going to go back to you, Dr. McKelvey. That's okay. Just about the heart failure stuff, because I do admit I find it challenging to manage my heart failure patients in my office. I think, and I think a lot of them are kind of seen by cardiologists. And I do find it a bit challenging to know who's got the football here. Like, I feel like I'm more passive following along with the treatment plan. I don't have a lot of say in what meds are optimized or not. So I'm just wondering how to maybe promote that collaborative care piece when a lot of our patients are being followed by specialists and it's not necessarily as collaborative as we'd like. I mean, as far as this program sounds like it would be a better way to do that in a lot of ways, but I'm just curious what your thoughts are on that piece of things.
So in an ideal world, the care should be collaborative. And in an ideal world, I would say you would refer the patient to me. I might go through the diagnostics, set a plan of care in place, and then the patient would come back to you you, in the case if you're dealing with best care, would have the educator there with you, helping you further optimize. I could review the patient again in a few months, but you would be optimizing these therapies over time, very quickly. And then if you ran into difficulties, meaning you were concerned about the blood pressure or you found the creatinine going up and you were uncomfortable with that, then you would call and we would work it through. So I agree with you completely that with regards to heart failure management, it's often a matter of, you're right, you don't know who has the ball and you're not sure exactly what you're supposed to do. And it becomes challenging. So if we could change the system and, best care, Chris and Madonna have been working very hard to do that. I've been a proponent to change it as well. And having educators within family health teams, I think, would be extremely valuable to help optimize these patients. And then it becomes a matter of making it clear with the specialist that you are optimizing. And when the specialist sees the patient again, these things have taken place. And finally, there's no way we're going to do this without working as a team. The family health teams have to, I'm going to say, come up to the plate, but I don't mean it the way it just came out. But we need to work collaboratively because these patients need to be optimized rapidly. As I said, within 3 months, ideally, starting the medications, all 4 within a month. And it's a team sport. There's no doubt about it.
Definitely.
Just a quick jump in, 15 seconds. I think the other issue that Bob and I have talked about has been around capacity in the heart failure clinics to actually have specialists lead the titration. With sort of 10,000 heart failure patients in the region, how is it that cardiology can effectively do that Q2 week visit or whatever to do that titration? So a broader swath of participation and expertise would probably get the job done.
Absolutely.
Wonderful. So now what we're going to do is move on to a case study on CHF, and I'll just hand that over to the team to get started with that.
Okay, so I have no control.
We could all say something about that comment, Dr. McKelvey, but we'll be quiet.
Thank you.
Okay. Aha. There we are. Are you on there, Bob?
I'm here. I'm alive and kicking. Next slide. Okay, so we're going to go through this case, and Madonna, are there polling questions with this or not? Madonna?
I think the polling questions were programmed, Bob.
Okay, fair enough. All right, so this case is a 67-year-old male, past history of MI in June 2019. Anterior EF was found to be 25%, and he was started on optimization of his medical therapy. And in August of 2019, his EF was still 25%, and he had an ICD implanted. In October of 2019, he was referred to the heart failure clinic by his family physician. And this was because he was describing edema and orthopnea, P&D, and shortness of breath on exertion. He admittedly was somewhat non-compliant with his diet. Next slide. So when he was seen in the heart failure clinic, his medications are, as you see there, bisoprolol 10, perindopril 2, spironolactone 25, Lasix 80, aspirin, and ticagrelor. And on the exam, blood pressure 104/70, heart rate 84, crackles bilaterally, jugular venous pressures at the angle of the jaw, 3+ peripheral edema, His sodium was fine. Potassium was 3.6, which of course is normal. Creatinine is 107. And in the heart failure clinic, we have the ability to start IV Lasix in the home setting, and the home care nurses follow along, and we interact with them with regards to changing dose. So IV Lasix was started at home. So now the question is, what would you do now? Increase the perindopril, add Entresto, add ivabradine, which we can talk about the rationale for that, because I realize that may not be a familiar drug. Stop perindopril and replace with Entresto, or start an SGLT2 inhibitor.
So the poll is posted, and you can select, I think, more than one option.
So I'm not sure if more than one question is showing. So just answered the first.
It is actually, I think.
Yeah, I'm not sure why. Sorry about that, everyone.
Okay. So
Just
to be
answer
clear, I guess,
question one.
right, exactly.
Hit submit at the bottom and you will be in.
I can't submit. I'm wondering.
It seems
Are
like you
there
might have to
some-
answer them all in order to, yeah, to submit.
So then shall we just maybe in the interest of time, bypass the poll, or Bob, and just discuss the responses?
Sure, that's fine with me. Maybe what we'll do is we'll go to the next slide and we'll show you what was done, and then I'll discuss the rationale for doing that. So what we did was we did start the patient on Entresto, and we stopped the perindopril. So on the previous slide, there was a choice that said add Entresto. So the point of that is that you can't combine Entresto with an ACE inhibitor, perindopril. You have to stop the ACE inhibitor and wait a good 36 hours before the Entresto gets started. I generally say to the patient, if it's a Monday, for example, and they've taken perindopril on the Monday, then they can start taking Entresto on the Wednesday. So Tuesday, the rest of Monday, Tuesday, and then Wednesday they would start. Entresto's twice a day, and the 24.3, 25.7 milligram twice a day dose is the lowest starting dose. I didn't start the SGLT2 inhibitor. I think that was a selection. And the reason for starting Entresto was the patient is obviously somewhat still volume overloaded, and Entresto, of course, is superior to the ACE inhibitor. And the fact that they're a bit volume overloaded is actually a good place to have the patient, because Entresto as well acts a bit like a diuretic and will help them further diurese. So then you can see we start on Entresto. 3 days later, the creatinine is still fine. His weight is decreasing as you would expect because we're diuresing, and his blood pressure is still fine at 100/75, and his heart rate's 85. So now 7 days later, he's back in the clinic, and the blood pressure is good. The heart rate's 90. The jugular venous pressure is now down to 3 centimeters above the sternal angle, which is normal. He has minimal peripheral edema. The lungs are clear. Potassium is still good at 3.7. Creatinine is still good, and he's in normal sinus rhythm. So the IV Lasix was stopped, and he was switched to a flexible diuretic regimen, meaning we described to him that if your weight goes up a certain amount, you take Lasix, and if it goes down a certain amount, you reduce the dose of Lasix. Next slide. So now what would you do to optimize its therapy? Would you increase the Entresto? Would you start ivabradine? Would you start an SGLT2 inhibitor? Would you increase the spironolactone, or nothing, because it is too soon to make any changes? Now, I guess it really isn't working here, the poll. So I will go through right now and discuss the responses here. So first of all, we'll start from the bottom. Nothing because it is too soon to make the changes. Well, that's not true at all. The Entresto was started about a week prior to this point in time. So it would be quite reasonable to increase the dose of Entresto. There's been enough time to see the full benefit of the effect in terms of whether or not it will cause further worsening of renal function or hyperkalemia or drop in pressure. So it would be quite reasonable to increase the dose of Entresto. Increase spironolactone, probably not. I think the patient was on 25 milligrams of spironolactone, which by and large is thought to be the target dose. I know if you read the guidelines, we have said you can go up to 50 milligrams daily of spironolactone or eplerenone, but most heart failure specialists stick at about 25 for the spironolactone. The SGLT2 inhibitor would be a reasonable choice as well, because now we would have the patient on all four, a drug from each of those four groups. And I'm starting ivabradine now. Ivabradine, you're probably not familiar with, but it's a drug that just reduces heart rate. It doesn't affect blood pressure. It doesn't affect renal function or potassium. It just affects the sinus node and will slow the heart rate down. And we often use ivabradine when the heart rate is still above 70 or 77 beats per minute, and the person is fully optimized on beta blocker therapy. So let's go to the next slide and we can see what was done. So in fact, in this case, we did start the ivabradine, and I know you would potentially feel uncomfortable to do that, but this would be a situation where we would co-manage and you would say, what choice should I make? And I would say ivabradine, 2.5 milligrams twice a day is the starting dose, and it's being used to lower the heart rate. I know it won't affect the blood pressure or any of the metabolic parameters. And when we saw the patient about 2 weeks later, the heart rate has come down a bit. The blood pressure is fine. The electrolytes are fine. The renal function is fine. So now what else would you do to optimize the therapy for this patient? Would you increase the dose of Entresto? Would you start an SGLT2 inhibitor? Would you increase Entresto and ivabradine, or would you increase the spironolactone? So now I'm not sure whether we have what was done on the next slide, but this you would, yeah, we don't, so go back then. So now in this situation, what you could do is start the SGLT2 inhibitor. That will get all four of the base drugs into this patient. You could, if you wanted, because the heart rate's still running 80, if you wanted to further increase the Entresto and ivabradine, that would be fine, because they don't interact. The ivabradine will not affect the blood pressure. It will just slow the heart rate. And Entresto, certainly, it would be time to start that medication as well. So you see, then you have a bit of selection, or you can choose a bit how you'd like to proceed. So in this situation, I probably would have put them on an SGLT2 inhibitor, and then on further optimization, get the Entresto up to target and the ivabradine up based on the heart rate. And finally, the rationale for starting the SGLT2 inhibitor at this point in time would be it's just one dose, whether it's dapagliflozin or empagliflozin for heart failure patients. Those are the only two gliflozins that have been demonstrated to be a benefit in heart failure. The dose to treat heart failure is 10 milligrams daily for both EMPA and DAPA. So that's how we do it. And any questions, I'm happy to respond.
That's great. Thank you, Dr. McKelvey. And thank you all for all the speakers today. Great presentations with excellent discussions that have followed. I just want to remind everyone that all the information will be shared to those who registered and will also be posted on the LMPCA website.